Right. Welcome everyone to this exciting podcast launch. This is the first episode of the Journal of Clinical Anesthesia's new monthly podcast where we highlight noteworthy articles from each issue. I'm Julian Rössler, Assistant Social Media Editor for the Journal and your host for today's interview. I would like to offer a really warm welcome to Dr. Matthew Pappas, the lead author of an article from our November issue titled Consequences of Preoperative Cardiac Stress Testing, a Cohort Study. Thank you so much for taking the time to talk with me today. So just following on the pre-anesthesia clinic, right? So you are very active in the Cleveland Clinic's pre-anesthesia clinic, or one of them at least. And that would lead me to my first question. So let's imagine between two appointments, between two patients, a resident comes to you and asks about perioperative stress testing. How would you explain your study to this resident in a really quick summary between those two patients?
Yeah. So if you order a preoperative stress test for your patient, you will increase the likelihood that that patient goes on to additional cardiac testing and interventions. You will decrease the chances that your patient completes the surgery that's currently being considered, and you won't help your patient live any longer. Those early trade-offs might be reasonable if cardiac care is more helpful than the surgery that's being considered, but you should think very carefully about the potential benefits of the surgery that might be canceled before you order such a thing, before you do such a thing. If you're considering curative cancer surgery, for example, those changes to clinical care almost certainly won't help your patient. Meanwhile, if a patient considering cosmetic surgery hasn't seen a physician in decades and probably just needs cardiac care, those management changes would be very reasonable. But you can't think only about the cardiac risks of surgery or the patient's functional status. The decision is both more complex than that, in that it requires thinking about the benefit of surgery, and in some ways it's simpler than that. It doesn't actually depend solely on functional status. It depends on whether the balance of benefits and harms of the surgery are positive, whether the expected benefits exceed the expected harms.
Right, that is a very useful answer. I'm sure the resident would be able to put that into practice quite well. So your paper discusses the cascade effects of preoperative stress testing. And like you said, it's leading to additional downstream testing and process changes. So, for example, right now, the ACC as well as the AHA have guidelines that recommend preoperative stress testing for specific patient groups with an estimated risk of major adverse cardiac events exceeding 1%. Could you provide some more insight into how these guidelines are applied in clinical decision-making right now, particularly regarding factors that influence the decision to perform preoperative stress testing at this time?
Yeah, so we published an analysis of what things were associated with an order for preoperative stress testing in BMJ Open in 2021 using this same cohort. And I think that earlier paper is probably closer to answering this particular question than the paper we're most focused on talking about here. So in this clinic, physicians were more likely to order stress testing for patients at higher risk of a major perioperative adverse cardiac event, and were more likely to order stress testing for patients whose functional status was low, as you'd expect based on these guidelines. I think that earlier paper also highlights some difficulties of the current guidelines as well. So first, risk of a perioperative cardiac event is not the same as risk of coronary artery disease. Yeah. So controlling for all other variables we tested, including risk of a perioperative adverse event, physicians were more likely to order stress testing for patients at lower risk of undiagnosed coronary disease. So if the goal of testing is to diagnose coronary disease, that's clearly suboptimal. We're not ordering them optimally for diagnostic purposes. Second, because there are multiple prediction tools here, RCRI and Gupta-Mica are the two that we looked looked at. And those tools don't agree on what constitutes a major adverse cardiac event, and whose calibration is uncertain in external data sets, and whose outcome ascertainment differed between the era that gave rise to RCRI and the era that gave rise to Gupta-Mica. There's not a stark dichotomization at any level of RCRI or at the 1% risk threshold as predicted using Gupta-Mica. That's, I think, in part, at least, an artifact of multiple different tools that don't agree on the outcome being predicted. Third, different physicians are differently likely to order stress testing. There was over a threefold difference between the 5th and 95th percentile physicians in this clinic, even after controlling for all patient and surgical factors. And finally, there was a temporal trend. So after controlling for patient factors and surgical factors and physician, a visit to this clinic in 2018 was still less likely to result in stress testing than one in 2008. And that was a continuous trend. It started before 2014. The 2014 guideline didn't seem to cause the ongoing decrease so much as it seemed to reflect it, or be perhaps a part of the same thinking that was already leading to a decrease in use of stress testing.
All right, very good, thank you. So the paper talks about the association between preoperative stress testing, as we do right now, and mortality, which is, let's say, the furthest cascade downstream. Yet stress testing itself is not therapeutic. Could you explain the mechanisms or downstream interventions that might mediate a possible association, considering the various potential interventions like angiography or PCI, or like you said, the delay of surgery? And how did you test for this mediation in your study?
Yeah, that's a good question. I can certainly try. There's very clearly a selection process here. Patients with more comorbidities, who are sicker in the colloquial use, are both more likely to be referred for stress testing and are also more likely to die. What we've tried to do in these few papers is to separate those relationships. So in our analysis in the BMJ Open paper, we showed how strongly various things are to stress testing. In this paper, we controlled both for those things that are related to stress testing and for the things that are associated with death. And so there are associations between illness and stress testing. There are associations between stress testing and death, and there are associations between illness and death. But controlling for each of those relationships, stress testing doesn't seem to change the chance of death. It seems to be a product of the earlier confounders and the selection of patients for stress testing. So, note that in that explanation, you don't need any downstream mediators to explain those findings. There could be one or more mediators, but it's not actually necessary to explain the findings. And it's hard to imagine what interventions those might be. So the CARP trial, McFalls and colleagues in the New England Journal, randomized high-risk patients to revascularization or no revascularization, and found no benefit. So I doubt it has anything to do with revascularization. A registry-based study of patients with coronary disease by Garcia and colleagues suggested that of patients with coronary disease, only those with left main disease could potentially benefit from revascularization. But there aren't many patients who went in our data set from stress testing to revascularization at all. And presumably very few of those had undiagnosed asymptomatic severe left main disease so as to potentially benefit from revascularization. So I am not aware of any interventions that both reduce operative mortality and that require a stress test to decide whether to do or not. And so I'm not sure there is any downstream mechanism after the initial selection for stress testing or no. If there is a downstream mechanism at work here, I think the most likely candidate is cancellation of surgery. Yeah. We know that non-cardiac surgery incurs some risk of death. The absolute risk in data sets is somewhere around 1.2%. Presumably some small number of those patients would have died without surgery. So the absolute increase is not exactly 1.2%, but but surgery does incur some increased risk of death. And we showed here that stress testing increases the likelihood that surgery will be canceled. Canceling surgery would certainly avoid some risk of death. Still, that doesn't help us very much when we think that a patient might benefit from surgery. We would generally hope to find ways of making helpful surgeries safer, not to simply reduce surgical mortality by avoiding all surgery.
That's a really good point to make. So, on a personal point of note, you used causal inference models to separate the effect of preoperative stress testing from confounding variables. Yeah. Me personally, this is something that I just came to know of in the last year or so, and I find personally very interesting from a methodological standpoint. So what challenges did you face implementing these models, and how, in your own words, do they enhance the validity of your findings compared to, let's say, more traditional approaches to observational analysis?
Yeah, that's a good question. I'll answer the second part of that first because it continues on our discussion of the selection processes just a minute ago. So the key advantage of these approaches, at least in theory, is the ability to disentangle causal from non-causal relationships. So if we were to draw just the simplest possible directed acyclic graph with our assumptions, we're interested in the effect of stress testing on some outcome, say mortality or angiography rate. And we know there are certain common causes, confounders that contribute to both. Risk of RCRI probably increases the rate at which patients are referred for stress testing and is associated with higher risk of death. And so under certain assumptions, there are certain techniques, including inverse probability weighting, that are mathematically provable to represent the causal effect. The actual effect of stress testing in the simplified example on mortality. Now, those assumptions are non-trivial. Like one of them is the assumption that there is no unmeasured confounding, which is obviously untrue in virtually any real-world data set. Which brings me to what I see as the biggest challenge of using these methods in clinical practice, which is, I think, common to any applied theory. There are a number of really brilliant theorists in this space who have written just incredible work about causal inference analysis using observational data. And so on the theory side, there are mathematical proofs demonstrating that IPW should represent the true causal effect under certain conditions. And there are papers with titles like Why Propensity Scores Should Not Be Used for Matching, criticizing one approach to using causal inference observational analysis, or the trouble with coarsened exact matching, criticizing a different approach to causal inference observational analyses. And those are, again, written by absolutely brilliant mathematicians who have deservedly won many awards for their work. Meanwhile, for clinical journals and most clinical reviewers, all of that is essentially a different language. One reviewer described a more technical methods passage in an earlier version of this paper as, I think that the line was nearly unintelligible, if I remember correctly. I think these methods can help us understand the world more deeply and be less wrong, and I think we should embrace them. But I think the theorists can find themselves in places where they make assumptions that can't possibly hold true in any real-world scenario, like the assumption that there is no unmeasured confounding, while most clinicians don't have the background to really engage with these methods. I think where we ended up in this paper with doubly robust methods is probably the best way that a paper like this can be done, and I'm really proud of it. But I recognize that my approach probably isn't precisely what a theorist would consider optimal and is simultaneously already more complicated than most of the audience for this paper would want to read. So I think, as with any applied work, threading the needle between different disciplines can be challenging. Not that it's not worth doing, just challenging.
Definitely. So finding the balance here between the theorists and the clinicians, that both are happy, both are able to understand the analysis that have been done, that's really challenging for sure. In the end, the question is, most of the time, nobody ends up being happy, but I think you managed really well in this paper to communicate complicated methodology in a way that I think is quite understandable. So
well, thank you.
Something I really liked about the paper.
Thank you. I think you must not have read whatever earlier version that was apparently nearly unintelligible.
Paragraph probably I did not read, yes. So looking to the future, based on your findings regarding that impact of preoperative stress testing, what do you believe are the key clinical implications? So how do you think future guidelines or recommendations should maybe be changed, and or are there specific areas where we need further research to better understand the implications of preoperative stress testing?
Yeah, it's a good question. I wanted this paper to be published in the same issue as our other paper on the diagnostic and prognostic value of stress testing. And I'm grateful to JCA for considering them jointly, because I always thought of them as a pair, really, from when I conceived them in the grant writing process years ago. So this paper analyzes the consequences of testing, what will change as a result of stress testing. The other paper, again, same issue, analyzes what you get in exchange for testing. How much does this test help you if you're trying to make a new diagnosis of coronary disease, and how much does it help you predict adverse cardiac events? And so I think of the two as a pair, and I think together they are more useful in thinking about how we should use this test. And all told, I'm not sure I see any role for preoperative stress testing, frankly. For patients who don't have a previous diagnosis of coronary disease and don't have an anginal equivalent, the pretest probability of coronary disease is just too low for stress testing to be diagnostically useful. If you really wanted to make a new diagnosis of stable obstructive coronary disease in this setting for some reason, a coronary CTA probably has better diagnostic performance. I'm extrapolating a little bit from outpatient and hospital workup of chest pain and attempted diagnosis of coronary disease, but I think that probably holds true in this setting as well. For patients with a new anginal equivalent, you should work them up as you usually do, which is not specific to the preoperative setting and which might require hospitalization. Chest pain sometimes does. So I don't think there's a reason to get preoperative functional cardiac stress testing for any diagnostic purpose. If you're trying to diagnose coronary disease, it's probably never the right answer. Now, for patients where the benefits and harms of a proposed surgery are closely balanced, such that you need a more careful estimate of the risks of surgery, NT-proBNP probably offers better prognostic information. They haven't been directly compared, the two. So, there is that caveat, but from Emma Ducep's work on proBNP and our work on stress testing, it sure looks like biochemical testing probably adds more prognostic information. And in this cohort, we showed that we could improve our predictions quite a bit if we incorporated data like hemoglobin into our predictions, which is almost always available and would only require implementing better prediction models that draw from EHR data. So I think the way to get better predictions of surgical risk is to create better prediction models that take full advantage of data we already have, and then to get biochemical testing in selected patients where the balance of benefit and harm remains closely balanced, despite our best possible prediction. Neither of those require the expense or delay or consequences of stress testing. So, I don't think there's a good reason to order stress testing for prognostic purposes either, which leaves us with only a handful of other ways in which we use tests. So Stephen Pauker would say that tests can be also used to gauge the severity of disease. And I suppose that's still possible here. In the preoperative setting, that might take the form of something like a dobutamine stress echo in a patient with known coronary disease, known heart failure, and chronic dyspnea. In that scenario, you'd be investigating multiple causes of dyspnea simultaneously, and you'd be trying to ascertain whether there were any acutely dangerous etiologies that require diuresis or management of ACS, and you'd be comparing it against some earlier test. So I'm not sure anyone actually has the data to inform a question like that. It would be a tiny subset of a subset of patients where you're trying to use this to gauge the severity compared to some earlier state. So, I wouldn't argue about a use like that, but that would be a tiny subset of patients and not a thing to be widely considered. So, which leaves us short on indications, I think, for preoperative stress testing. If it's not diagnostically useful and it's not prognostically useful, and the severity question is only very limited. As for the other part of that question, I don't know whether these papers will influence guidelines. As I said, I think these two papers are the best possible versions of their respective analyses, and I'm proud of them. And so I hope they do influence clinical practice. And if they're influencing clinical practice, they will, either before or after that, probably also influence guidelines. And I imagine that new guidelines are in the works since it's been nearly a decade since the last ACC AHA guideline release. But I haven't been asked to write them, so I just don't know. Yeah. I will say that I would be surprised if we're still thinking about preoperative stress testing in 20 or 30 years. As I said, there are better tests to diagnose coronary disease. There are better tests to select patients for angiography. And there are better approaches to predicting operative risk. There are also no clear interventions that are done differently based on stress test results and that then improve surgical outcomes. I think functional stress testing has multiple intended purposes, but it isn't actually the best choice for any one of them. And so I think if we are very clear about what our purpose is or our purposes are, we will end up in the preoperative clinic at one or more things that are not functional cardiac stress testing.
That's a really good point to make. And well, I can tell you that these two papers will influence my clinical practice, at least for sure. Matt, thank you so much. This is already all from us for this interview. Thank you so much for taking the time to talk with me today. To our viewers and listeners, you can read the article, Consequences of Preoperative Cardiac Stress Testing, cohort study in the Journal of Clinical Anesthesia's November issue. So again, thank you very much. And
thanks for having me, Julian. It's been a pleasure.
All the best to you.
Cheers.
Bye-bye.